welcome and thank you. This is a very important panel, I think, not because of me, but because of the panelists, excuse me, on a very important issue. So I'll speak as little as possible, but I do want to say a few things. So the first thing...
Just move up a little. The light is hitting you down.
Okay, is that better?
Yeah.
Okay, first of all, I don't do paper. I only do phone. So that's why I'm holding my phone, not because I want to check my WhatsApps while I'm speaking. It's bad because when there are other speakers, they think I'm not paying attention, but I'm actually writing most of what they say down. So the first thing on my note is to explain what Barkai is, because whenever I say it, people think, oh, it's a method of learning Tanakh. And so Rabbi Short did a very good job of that. So I'll just tell you that if you want to learn more, it's IsraelRabbis.org. I want to also thank everyone who made this day possible. It was really my honor when Rabbi Shor called me and said that the OU wanted to do something like this. And I think I was at least one of the first calls that he made because of my experience in teaching, Israeli rabbis or training Israeli rabbis in many areas, including mental health. And whether that wisdom that I've attained over the last 13 years doing this could be applied to the Anglo community in Israel as well. And like you said, we've really become such good friends that 2 days ago, when we sent out the wedding invitations for my son's wedding in 4 weeks, I sent him an invitation. So, wait, I just lost my... Okay. And Zamira and Ira and all the other people who really helped make this day possible. Okay, so we've heard all day about sort of the kum va'aseh, right? What we should be doing as rabbis, educators, rebbitzins, community leaders. But there's also a lot of shev va'al taseh. Right? And Rabbi Bredowitz, one of the things he said this morning was that sometimes you want to do so much, but if you do the wrong thing, you could actually create very big problems that you wanted to solve a problem, and instead you create a problem. So sometimes, despite all the desire to help and do, sometimes it's about retreating and knowing when not to do something. And that's basically going to be the subject of this panel. We also wanted to include, in a bit of a broader way, a discussion about the proper relationship between mental health workers and rabbis and rebbitzins, as well as a little bit of a discussion about professional ethics as it applies to this department, so to speak, of mental health. So we have three very distinguished panelists, and if I read all their bios, we'll be here until Tanit Esther. So because of their numerous accomplishments. I know all of them, and so I'll just say something nice about all of them. You could Google all of them, and they, like I said, they're all the top people in their field. So Dr. Zev Alexander is as one of the top the top psychiatrists in Jerusalem. He's very much sought after. Many accomplishments. Has helped many people in numerous ways. And something that it did say in his biography is that he is able to combine the medical aspect with talk therapy. And if anyone knows anything about psychiatry in Israel, right, most of what happens is you go and you get your medication, whatever. You're there for 15 minutes, 10 minutes, and then you leave. And Dr. Alexander is able to really combine both in a very masterful way. So, Dr. Alexander, we're very happy that you're here with us. Thank you for taking the time. And I just have to find our WhatsApp so I can read the questions. Sorry. So I guess I'll start with, do you believe that a partnership between the mental health worker and the rabbi is a good idea?
I want to say a few things as background before answering a very specific and very important question. I think it's very important to define some terms.
Okay.
There's a lot of people in Eretz Yisrael and in America, in England, Australia, that talk with each other. There's coaches, there's tomech, there's social workers, there's PhD, there's PsyD, there's MD, there's psychoanalysts, there's different schools of psychoanalysis. there's a lot going on in the world of treatment. When a Rav sits with somebody, I think we have to define what the person who is going to the Rav thinks is happening, what the Rav is thinking, what the Rebbetzin is thinking, what everyone goes in with the expectation. Because the treatment relationship is unique. And we've learned that it's important to have a certain kind of frame, boundaries, a time and a place, a specific amount of time, payment involved. So when a doctor, or let's say a psychologist, a physician, meets with a patient, there's something unique happening. And I think that there's a lot of value to saying not every professional who has a license and has training is good. It's very important to say there's a lot of duds in nephrology and in dentistry and in car mechanics, and psychiatry has a lot of terrible practitioners in every country. And so there's fantastic chaplains who don't have training in grad school beyond chaplaincy, but are the nicest people and are wonderful. So I think to go back to the specific question, it depends. Each case is going to be different, but the goal of treatment, I believe, my background is in psychoanalysis. The goal of treatment is to give a patient the ability to have an authentic, individual life experience where they make their choices. If a Rav is too connected to that person to allow that person out of whatever frameworks that they come from that might be part of their pathology or part of their conflict, then the Rav sitting with a person can exacerbate the symptoms. And oftentimes, I should also say as background, people who treat, we say hamol yimol. So in psychotherapy, it used to be if you were in training, you were also in treatment. That's not really the case anymore. Not everybody has been through treatment. We expect people to maintain supervision for a while, but like the previous speaker, I don't know the process for rabbinic supervision after training, but there's a lot that can go.
It's very simple. There is none.
There's a lot that can go wrong. And the title of the talk was on ethics. I reviewed in the past few days the websites for the American Psychoanalytic Association, the American Psychological Association, the American Psychiatric, and I even looked at the social work one. It's fascinating to look through the ethics guidebooks of the secular world. They all mention boundary violations, and we're all at risk. We have to know that we're all at risk, and we have to know that treatment doesn't prevent boundary violations, and it's not just about things that are, egregious. The concept that they bring up on a lot of these websites is a dual relationship problem. I don't want to steal if you're nodding out. But I was thinking about it. I try really hard never to go to shul where I know a patient of mine davens. And that means I have to move shuls a lot. And it's not fair to them. And if I know that that a patient is involved in a thing that through 16 different connections it might be helpful to me to have them comment on a thing, like I used the word car mechanic before, but let's say I'm new in town, I don't know where to bring my car in Talpiot, but this person would, I can't ask. And I think that there's so many hundreds of tiny little things that can affect treatment. When you ask people what went wrong with your treatment, I don't know if Rabbanim get the level of supervision detail to see. So when I speak to a patient who's in the yeshiva and their treater is one of the Rebbeim in the yeshiva, I'm thinking, I don't know how that may be, but it seems like we really need to give a patient space and privacy, that the only thing that happens when they talk with the professional is that they're talking with the professional. And the Rav, as the bridge back and forth, maybe in the introduction, maybe in the referral, but in an ongoing way, I think it stymies the person's individuation and growth and agency and all that stuff. The anecdote I'll share from training is, what consult liaison psychiatry is like. When the Department of Surgery calls you because the patient wants to leave AMA, they call psychiatry, will you come? The person, wants to leave, but if we take out the line, they're going to die. So can you come see them so that we can let them leave? Or can you convince them to stay? So the consult liaison secret that they taught us in residency is the surgical resident is the patient. Why are they consulting you? The patient is just a patient. But the Department of Surgery can't figure out how to do this, how to talk to the patient. They're fully capable of assessing capacity. They're fully capable of spending another 20 minutes and being like, what's wrong? What did we do wrong? But they bring in psychiatry because the surgeon doesn't want to. And so the same thing, we have to analyze the family circumstances, the religious circumstances, the whole, what's called the objects in a person's life.
But you're discussing a lot of the challenges,
Yes.
right? I think my question is more towards, let's say a rabbi understands those challenges
Okay.
and wants to avoid them, right?
Right.
He passes somebody on, refers them to Dr. Zev Alexander, right? So after that happens,
Yeah.
right? The rabbi doesn't intend to continue seeing them in any kind of therapy relationship. Is there a relationship between the rabbi and you? Meaning, in order to help the patient, is that possible? Meaning, I, as a rabbi, I see the person at Mincha and Mariv, and on Shabbos, and at Kiddush, and at the lecture, and at the Shir, and I spend a lot more time with him than the 50 minutes that he goes to you. So
50 minutes weekly or 50
Weekly.
minutes every 6 months?
No, 50 minutes weekly.
So then I'm not sure that's true.
You're not sure that what's-
Because a Rav has 100 people.
Right.
Is the Rav really interacting with the person because they see them at Mincha? Meaning the person's telling me about their dreams, they're telling me about their relationships, they're telling me about their fears. I would treat a Rav's input the way I would treat a parent's input. Meaning it's useful, I guess, but the real thing that we try to help the patient see is this is all you. Like, what do you bring to the room?
So if I'm a rabbi in wherever, in Ramat Beit Shemesh in the shul, and I have somebody, I refer them to you. After that, are you saying from a mental health perspective, my job is done?
Well, let me think of a scenario where what you're saying is different. If somebody has a severe psychotic illness, where their goal is to not be in the hospital but to be maintained in the community, so then I would say the more support we can provide for a patient, like who's bringing them for their weekly blood test for clozapine. If the rabbi can organize a volunteer from the community, that's amazing. That's a type of psychiatry where somebody is, let's call it low functioning or very high needs. If somebody's, manic at shul and the whole community saw it and it's very upsetting to the community and to that family, so then maybe there's a role for the community to be part of the healing. But let's say the bread and butter psychiatry, a person's having panic attacks, depression, I think that they want real privacy and wouldn't want their clinician to talk. But sometimes if there's an absent family or there's big problems, then it could play a role. I was thinking of another scenario where what does a Rav do that we don't do? Actually, I want to quote the source of this. When I was in training, Rabbi Shlomo Katz said to me, what I noticed about mental health is you don't offer anything. You dissect everything. I thought it was very smart. Our job is to be minateach. So we hear what the patient has to say. But I don't get up, and say, okay, here's the positive things you should do with your life. You should have this as your hobby, and you should believe in these things. And oftentimes, a rabbi doesn't have to follow the protocol of being neutral. You get to give Dvar Torah, you can inspire the person. The pitfall of a lot of doctors you might have seen over the years is we all want to be rabbis, and the rabbis want to, be mental health professionals. And we both have that Yetzer Hara, that we want to offer the patient a little chizuk. I don't think that's good treatment. If I do that, I notice I'm what's going on for me today? Why am I doing that?
I could interview you all day. There are many important issues. I want to ask you one more question, and then we'll move on to the others because we don't have unlimited time. So we've been hearing all day, and those of us who are educators and rebbitzins and rabbis, we talk about it all the time, that our job is maybe to identify the fact that there's a problem and then refer them to someone like you. So it's very easy to say that. But I want just to get a little bit more sophisticated, a little bit more nuanced. So somebody comes into my office, Rabbi, fine, I want to make an appointment with you, comes into my office, and he either tells me or she tells me explicitly that they're suffering from some kind of mental health problem, or I detect it, or I sense that there's some kind of issue going on here. They come in to talk about something else, but I really understand that there's something else behind this that may be a mental health issue. So at what point do I say, okay, go see a mental health? Is there anything more that I could do, or is it just right away, refer them out?
Thank you for bringing up this important opportunity to make a public service announcement. We still suffer from stigma preventing people coming for treatment. And the more we, as Rabbanim, psychiatrists, social workers, normalize going to treatment for ourselves, for family, it's not a big deal. This one goes for this type of physical therapy. This one goes for, equine therapy. This one, early and often. Make referrals early and often and make it not a big deal. I am shocked. I've been here since 2017. I am still shocked. Everybody knows the famous syphilis research in America, the Tuskegee, right? Where they just let the illness go and watched. In Israel, the level of psychiatry care is so abysmal. When I meet a 38-year-old who's had panic attacks daily since they're 16 and never seen a psychiatrist, I think this is a first world country. How is this happening? So just right away, just say you should see a psychiatrist. The same way if somebody had one diabetes attack and their sugar was 400 or whatever, you would send them immediately. So psychiatry, there's not enough psychiatrists, there's not enough therapists, there's certainly not enough for children, but refer and make the community aware that it's totally cool. I think that this would be helpful. This is called a panic attack, or this is called anxiety, or you're having, struggles because your parents are going through something at home. It's fine. We can find you somebody to deal with. And I want to say one last point. There's a psychologist on Twitter named Jonathan Shedler. If any of you are on Twitter, you should follow Jonathan Shedler. He's a genius, and he's
Spell that?
Shedler. I think he's in Colorado. But what he says is, he says a lot, but what he said is people will say, oh, I tried therapy and it wasn't good, I'm never going back, after seeing somebody 4 times. He says it's an interesting thing. You don't hear a bad song and say, well, I'm never listening to music again, right? You go to a restaurant, the pizza wasn't good. That's it for Italian food. But people give up very quickly because that's what Freud talked about. This is resistance. So the Rabbanim can recognize it's okay. It's okay that it didn't feel great the first appointment. It's okay, it's expensive, it's okay, it's far away. To encourage people, we'll find you somebody else. Because, if you think that there's an issue, it's like with appendectomies. You should refer more people for surgery and have their appendix be normal than miss even one. So it's okay to take out a healthy appendix every once in a while so that you never miss. This is the concept of specificity. We want to be sensitive and specific in our screening, but go for it, refer, tell them, I have somebody for you, or why don't you talk to this person? And I think that's a great question because it would help decrease the stigma. The frum community, all the stripes are still a little bit more sensitive than other populations, and it's getting in the way of people's health.
Thank you.
Thank you.
I have more questions about referrals, but we'll go to the others, and then if there's any more time, we'll go back to that. So, Judge Phillip Marcus, I will read a little bit about your bio because I'm not sure everyone is as familiar. So, Judge Phillip Marcus was born and educated in England. He moved to Israel in 1978. He was admitted as an advocate at the Israel Bar in 1979 and appointed a judge of the Jerusalem Magistrates Court in 1995. He served as a judge of the family court from its opening in 1997 until his retirement in 2012. It goes on for a while because you have so many accomplishments, and when we spoke on the phone and when we spoke out there, I don't understand when you sleep. So one of the areas that you told me when we spoke, there's some kind of echo here, right? One of the, I don't need a microphone, do I? One of the the areas that you told me that you are involved in is the issue of professional ethics. And Dr. Alexander just mentioned the whole issue of professional ethics. So I want to add on to what, sort of continue what he said, and then have you address it as well. So when you are a member of, when you're a psychiatrist, you're a member of the American Psychiatry Association and whatever it's called, and the Psychological Association, and the Plumbers Association, and the car mechanics. And the truth of the matter is that in the Orthodox rabbinate, there really is no ethics, conduct of ethics. I looked it up last night. I have it on my phone here. I won't read from it, but in 2018, not so long ago, the Rabbinical Council of America finally put together a code of ethics for its members. Now, and it addresses a lot of things that are specific to the rabbinate, right? Meaning, if you are a rabbi and a psychologist, are you allowed to see somebody in your shul, right? And other things of that nature. But could you just give us a little bit of, from somebody who deals in this as a professionally, could you sort of tell us what the whole idea, the whole notion of professional ethics can add to this idea of rabbis and rebbitzins and educators dealing in mental health?
Firstly, thanks for the, I think I can manage that. Thanks for the invitation, thanks to Ira, thanks to Get Help Israel.
Oh, sorry. That reminds me, the most important, or not the most important, one of the most important things is that Judge Marcus serves on the ethics committee of Get Help Israel, GHI, which our good friends Ira and Tanya Prachko started not so long ago and have made an enormous contribution to mental health in the Anglo community in Israel. Ira had to be in America at this time and he couldn't be here, but he has a large part of the credit for making today possible. So.
Okay, thanks. Korosatov never goes away. I've been studying and lecturing to counselors and professionals in many fields on professional ethics because I've seen that there is a lot of misconception about what ethics are, and also, as Rabbi Fine says, there are some professions where there is no written code, or if there is a written code, it doesn't include all the things it needs to include. So I'm not going to give a 2-hour lecture, or even a 1-hour lecture about what are the constituent parts of professional ethics. I'm going to speak very briefly about some of the things which, in my view, are likely to come up when a rabbi or a teacher or a rebbitzin is faced with someone who may know, may not know, and is being asked for help. The principal thing that has to be understood is that somebody who comes to you for advice thinks that you know better than they do what is required. That puts you under a colossal responsibility to stay within the bounds of your professional competence and to know where the border is between that and the other professions you may be involved in. What, as Donald Rumsfeld said, the problem isn't what we don't know, the problem is what we don't know that we don't know. And that means that a rabbi, somebody who takes his role seriously, has to know enough about the other fields which he may be involved in order not to cross the line. The trouble is that there's so much rubbish out there, there's so much fake science, there's so much noise that it's very difficult sometimes to distinguish what is the real idea, what psychologists are supposed to do, what psychotherapists are supposed to do. And where the borderline is between mental illness and simply being upset. It's particularly the case, there is an extremely important article about concept creep, in which the writer, who Halpern, I think his name is, describes the way in which psychological concepts like trauma and like even words like violence have become extended way beyond the original scope in psychology and in the other sciences, and they've been dumbed down. I read a piece about a demonstration at Exeter University in England last week. There was a few Jewish students manning a desk about what's going on since October the 7th, and one of the pro-Palestinian protesters said, by sitting there, you are violent. And I thought, violence? It's been flattened and it's been spread way beyond. So the terminology is difficult. You said that there is a resistance to getting help. Mani psychi, that's the response that you often get, maybe dumbed down even from that. So the first thing is to understand what you know, and also to understand what you don't know, and that will give you the clue when to refer things out. But there are several other things that a rabbi ought to know, and these are ethical, legal issues. For example, confidentiality. Everybody knows that a rabbi has to keep confidential anything that's told to him in confidence, and it's to be presumed that he's not going to blab about things. But there are limits to confidentiality. For example, the law provides that in any case where a professional, or even a non-professional, has reasonable grounds to suspect that an offence has been committed against a child or a person who is not able to look after themselves, there is an obligation to report to a social worker or to a police officer. That means that although the word moser is still part of our vocabulary, the law requires, and there is a criminal sanction, if a rabbi doesn't report something he should have reported, 6 months imprisonment. That's not nice. And therefore, a rabbi should familiarize himself with the limits of confidentiality. The rabbi has responsibilities not only to the individual congregant. The rabbi has responsibility to the family of the congregant, and particularly where there is marital strife, to the children of the couple, and also to the kehillah, and also to the state. So that the realm of the one-on-one talk is fine, maybe for a psychoanalyst or a psychiatrist or psychologist, but the rabbi, because he occupies a position in a community, has to take the different concentric circles of interest very seriously. There's another issue here, and that is the halachic issue. And the halacha does tell us a great deal about human relationships. And certainly a rabbi is expected to be familiar with the, not only with Choshen Mishpat, but also Ben Adam Lechaveiro. And that requires a certain mindset. The last thing I want to say is that we have to be very careful about the language we use and the terminology we use, because there are huge differences in the medical terminology, the psychological terminology, the legal terminology, and the general terminology. How many people here think that schizophrenia is a split personality? Well, I'm very pleased to see that, because until about 15 to 20 years ago, they thought schizophrenia was a split personality. How many people here think that a borderline personality disorder is somebody who lives in Metula? well, there are, unfortunately, lawyers and other people who still think that a borderline personality disorder is somebody who, doesn't like living on the border. But these words are, the general public may be thinking in these terms. And so we have to be very careful as to how we speak about these things. That's on one toe, rather than one foot.
I have one more question for you.
Yeah.
So we said before that you are on the ethics committee, is that what it's called,
Yeah.
of the GHI? So first of all, why is there a need for an ethics committee, and what do you do?
Any professional organization needs to justify its existence and make sure that the members of the organization are behaving in a proper fashion. The mental health professionals who are members of Get Help Israel are all subject to their own professional ethics boards. It may be in the Ministry of Health, it may be elsewhere. However, GHI, like any organization which puts out the names of professionals, has to make sure that those professionals live up to the standards that the organization wants to be adhered to. And that means that although a client may come with a complaint which may be appropriate for dealing in the professional association to which that professional belongs. Nevertheless, that may take a great amount of time, and in the meantime, GIHI wants to stop referring people to that professional because by including that professional in the list, GIHI is making a representation that that person is competent and ethical and decent and does his job properly, so that the ethics committee doesn't sit regularly, but when there's a complaint, it's dealt with seriously, but it's dealt with pretty quickly. So that obviously we will get information from the complainant, we'll get information from the professional involved, and we'll reach a decision as to whether that person should be or should not be removed from the GHI list.
Great. Thank you. I think that there needs to be a lot more cooperation between the legal sector and the rabbinic sector. So I'm so glad that Ira, suggested that you sit on this panel, and you've certainly contributed a great deal. So now, Dr. Alex Mondrow. So we talked about split personality. So you're a rabbi, you're a psychologist, Dr. Mondrow, and so I'd like you just to give a little bit more. He was the rabbi of the synagogue at the Albert Einstein College of Medicine. He recently made Aliyah and has a practice here in Jerusalem as well as in Teaneck. That's what it says here. And he does a lot of very other important things. But I think the focus here is also that he does a lot of training at REIT. We're not going to get into this now, but a very important part of his work is emotional intelligence and rabbinical students and rabbis, which is very, very fascinating. And maybe we'll have another conference and talk about that. But why don't you talk about the split personality and what it means to be a rabbi and a psychologist. Right, yeah.
Multiple personalities. Okay, thank you. It's hard to be the third in the line here, but so I'll share with you a couple of insights, and hopefully that will sort of build off of that. I think it's very interesting that I was a rabbi first. I was a rabbi for about 7 years before I completed my doctoral training. And then I invested myself heavily in my doctoral training, and now I'm trying to integrate the two in different ways. But it really is challenging. I think one of the pieces which really both of the other panelists alluded to is really there has to be an element of self-awareness, an understanding of what your professional competencies are, what your strengths are, what your weaknesses are, but also understanding perhaps most powerfully what you know and what you don't know, and also the role in which you're playing in a particular moment. It's actually very interesting. One of the largest differences that a rabbi, I think, differs from the way that a psychologist will, and very often, I think really both of the speakers alluded to, is that a rabbi very often is functioning in a prescriptive capacity. A rabbi very often gives prescriptions. They're saying, is this kosher or is it not kosher? Can I go here, can I not go here? Am I allowed to do this, am I not allowed to do that? You're paskaning halacha. And very often, not always, but very often they're being told, we're in the frame of mind of both either halachically or in an ethical kind of way, prescribing what should be done. Now, not only prescribing in terms of medication, but there's a way of prescriptively telling people what they should or should not be doing. As a psychologist, it's very often, almost always, it's the opposite. We're either observers or we're describing. We're in a descriptive role. We're not in a prescriptive role. And the way of functioning is very, very different. And so it's a very interesting thing that over time, for example, in my practice, when I have families come in or individuals come in, and they know my smicha might be hanging on the wall right next to my doctoral degree, but I tell them very clearly, I want you to know, in this capacity, I'm not a rabbi. It's true, I have rabbinic training, but I'm a psychologist. And I will refer them, if it's a halachic related question, or something along those lines, and it goes back in a certain way to what Dr. Alexander alluded to in terms of having a multiple relationship or a dual relationship. It's very complex because I'm not their rabbi. And I will very clearly tell them, I'll say, I'm your psychologist, I'm not your rabbi. Then sometimes it's a flip, and it goes back to the multiple personality pieces, is that sometimes if somebody's asking me a shayla, if I have, let's say, a student of mine who's asking me a halachic question, so I might do the opposite. I might have to say, look, I'm going to answer you based on, let's say, the Shulchan Aruch, but you should speak to your mental health professional about the application in this particular case, because I'm not your psychologist, I'm not your psychiatrist. And it's a very, very delicate, it's a delicate balance to strike that's probably almost impossible, as much as I like to say it out loud, that I try to, but it's a very, very difficult and a very delicate balance to strike between being a psychologist and a rabbi. But I think it first starts by understanding to some degree the role that's different, A, and then also the self-awareness to understand, A, what's being asked of me in that particular moment, and how am I functioning in that particular situation. I'll just add one piece which I think is very important for the rabbinic and the educators, which I think is something that really, again, it was touched upon, but I just want to sort of consolidate some of the points that the previous speakers mentioned, which is that I think number one, first and foremost, there has to be a baseline element of education. Is that the only way, like Rabbi Marcus alluded to, which is that, not Rabbi, Judge Marcus, I'm sorry, Judge Marcus alluded to, is that it might, or Dr. Alexander alluded to, anything can be run of the mill, but the language that we use, we have to know what we're talking about. There has to be, we live in a day and age where it's not okay to not have a baseline understanding of mental health and the different components of mental health. What it means, we're not asking you to diagnose, we're actually asking you specifically not to diagnose. And we train Rabbanim, one of the things that we're looking for, I'm not saying to you to diagnose, but similar to what Dr. Alexander alluded to, I want to know that I have to refer somebody. So like, if God forbid somebody's having a heart issue, I'm not going to pretend that I know what's going on with the heart issue, but I'll know that, well, if it's a suffix, I better refer them to a cardiologist. That would make a lot of sense. And so, in a similar way, I have to know enough to know that I'm the eyes and the ears on the ground. And it could be, as Dr. Alexander alluded to, that a rabbi may not be spending as much time really, even with a person, even though it might look like it. But the once a week that a person's with a therapist, they'll be more involved. But the one thing the rabbi will do is they'll have more exposure very often to the person. They'll see the person. They'll see the person in their natural environment. They'll see them on a more higher level of frequency. And a rabbi, an educator, a rebbitzin, a rabbanit, whatever it is, that each of them has to know enough to know, wow, this is something that needs to be looked at. And if there's a suffix, exactly like Dr. Alexander said, there's no harm. There's no harm. The same way that we would say in any other medical field, we would never say, maybe you'll be okay. Don't ignore the chest pain. Really? So you see somebody not functioning in a proper way with a baseline education, and a person has enough humility to say, look, I don't know what's going on here. You refer out. One of the things, I'll say one more point, and I'll pass on the mic.
I just have a question about that.
Yeah. I'm just going to make one small point. One thing that I find very helpful when we train rabbis is that they should have someone they can talk to. Never obviously violate any elements of confidentiality. But if I'm a rabbi in Yerushalayim and I want a mental health professional, I should strike up a conversation or have a relationship with Dr. Alexander so that if I'm concerned, I can say, hi, I'm Rabbi Mondrow. I just had a quick question for you. I have a congregant or a student of mine. I'm not sure about such and such and such. Can you just guide me for like 10 minutes? And over time, if you develop a relationship, the same way a psychologist might have a relationship on the reverse with a Rav because he has a shiloh the other direction. So having that relationship is invaluable. And that relationship can really help to be able to identify things, to be able to understand, have a better nuanced understanding. And if we grow in that way, we both defeat the stigma, but most importantly, we help the people that are coming to us.
So I just want to get a little deeper about this because Dr. Alexander, you seem to suggest that there's a very clear demarcation. There's once the rabbi hands it off to the mental health worker, there's really no more of a relationship. You seem to be a little bit more Mako, but what I really want to say is, yes, I may not be totally focused on that congregant like the psychologist is for the 50 minutes when I see them at Mincha, because there's 100 other people at Mincha. But at Mincha, I may see him doing or her doing something that maybe the psychologist didn't see. And maybe I should be in a position where if I had a relationship, I could tell the psychologist, and that could help the psychologist in terms of their own treatment, right? And also, similar to that, not totally similar, but sometimes a rabbi can do something that a psychologist can't. So I'll just give you one example. I've gotten calls several times from psychologists. It's only one example, but it's an important one, right? Tell this person who's suffering from anorexia that they must eat on Yom Kippur, right? So if I tell them, they're not going to listen. But if the rabbi tells them, then they'll feel much more comfortable. So if there's no relationship between the mental health worker and the rabbi, how could those things are helpful? How could those things happen?
Okay, so I'm definitely not going to do justice to it, but I don't disagree with Dr. Alexander. I was speaking about my own struggle sometimes being a rabbi and a psychologist together. But I absolutely fundamentally agree with Dr. Alexander, both on a confidential and ethical level, but even more, but in different plane in terms of care, in terms of the nature of the care. Once a person becomes a patient of a psychologist and a psychiatrist, and it's related to a mental health issue, the doctor becomes the quarterback. The doctor is the coach. The doctor defines everything, obviously within the contours of confidentiality, absolutely. the idea that a psychologist or a psychiatrist can go to a rabbi and tell the patient to eat, that's a blatant violation, I think.
No, with a vitur sodir.
Oh, okay, fine. No,
Right.
so that's a question. That's a clinical decision. That's a
Right.
clinical decision.
No,
We don't-
obviously,
Yeah, no,
without that,
that's actually a clinical decision
right.
that sometimes we do actually employ, sometimes,
Right.
especially when we're treating things like eating disorders or OCD, things like that, where we will have the rabbi sort of partner with, and it's something that's necessary, but it's a clinic, but fundamentally, it's not a halachic decision. It's fundamentally a clinical
No, for
decision.
sure.
And so in that case, I personally think that as long as the physician, the psychotherapist, the psychologist, whoever it is quarterbacking it and saying, look, in this particular case, we really need to utilize the force, the strength of the Rav, of a Dayan, depending on the context in this, especially in Hasidic communities in different ways. There is a lot of value to incorporating, but again, it has to be within the clinical framework that the doctor decides, obviously within the parameters that are set by confidentiality completely. And to me, I just think, just as far as referrals go, and goes to your point, I really do believe once the referral is made, it really becomes, it's no longer the rabbi's choice to be involved at all. The only way that I might suggest, that I have utilized sometimes, and in a way it has to be with the permission of the client, is simply letting the person know, I'm here for you. That's it. And that is actually something, and I'll pass it on to John Marcus, is that one of the primary differences between a doctor, a psychologist, a psychiatrist, and a rabbi, it's important to know this, is that there are very, very strict boundaries when it comes to a psychiatrist, psychologist. But a rabbi, it's not that the ethical boundaries might be different, but the reality is different. You're on the ground, you might be in and out of their homes, you might see them in shul, you might be at a simcha, you'll see them everywhere. You'll see them everywhere. The rabbi is definitely going to daven in the shul where his congregant is davening, whereas the psychiatrist is going to run away from him. I actually don't know where you daven then. You daven in your living room. Maybe but I think that so in that sense, there really is there's a fundamental difference between the role that a mental health professional plays and a rabbi plays, but as a supportive character, again, with the agreement of the person involved, to say, look, I'm just checking in with you. I'm not asking you to get involved in your care, in your therapy. I'm not getting involved in the analysis, whatever you're doing. I just want you to know I'm here for you. I feel an achrayas. I sent you to Dr. Alexander. I feel an achrayas that I sent you. If you need anything, I'm here for you. That's a supportive role. I'm not dumping you off and then jumping ship. That, I think, is actually a very crucial role that also minimizes the stigma that has a mental health, because you don't treat him any differently. Just because I sent you to Dr. Alexander, I'm still not going to talk to you. The opposite. I'm treating you exactly the same. If anything, I'm here for you more, but only in a positive way, not in a way that in any way affects the treatment in itself.
Judge.
Yeah. I'm not familiar with the role of the quarterback, but I am familiar with the role.
I realized that was a culturally inappropriate.
But
sorry.
I am familiar with the role of the tripwire, and the judge has an important role as being the tripwire. He may be the first person who has any kind of understanding that there is behaviour which points to a psychiatric problem or a psychological problem or a relationship problem, and particularly by no leveino. Unfortunately, there are rabbis who put shalom bayit above everything, and they've adopted a Catholic attitude to divorce, no aleinu, and they haven't read Ein Adam Dar Im Nachash B'Kfifa Achas. You don't live with a serpent in the same basket. And unfortunately, there is a tendency to adopt values which are not Jewish values, they're values from outside. Just want to point out one more thing, and that is the importance of introspection. A person has to know himself in order to be in any kind of position of authority. You have to know what your predilections are, you have to know what your prejudices are, what your biases are. Because if you don't, then you're going to make mistakes. That should be an essential part of training for anybody, not only in the mental health profession, but in any profession. Because, and that leads to another thing. You must not suppress those predilections. You must be aware of them all the time. I remember when I was hearing the small claims, I had a case involving a collision between two vehicles. And the plaintiff comes along, Odom Yishuv, and then the defendant comes in. He's one of the Rosh Yeshivas from Mir. I didn't know him at all. I had no personal contact, but I had to hold onto the chair not to get up. Because when the Talmid Chacham enters, you get up. That means I had to be aware of my immediate tendency to get up in front of a Talmid Chacham, but to be aware of the problems that it would cause if I were to appear to be discriminating in favour of this Talmid Chacham. So you have to know yourself, and it should be part, I hope it's part of the training of rabbis, that they should be taught that tshuva means identifying the bad points and being aware of them, but also identifying the good points and being aware of them as well.
Great, thank you. Okay, we have a few more minutes, so I did say I wanted to get back to referrals. So I'm going to start with Dr. Alexander and then go back to Dr. Mondrow to fill in. Refer. So you said before there are a lot of duds out there. So could you give us, like, maybe not the 10 commandments, but the 3 commandments of referral? What should rabbis know when they need to refer somebody?
I think that we're fortunate, certainly in the Frum community, that we're connected to each other. If you're in Nebraska and you're an endocrinologist and you need to refer to an orthopedist, if you just show up, you just have to wait and see. It takes a long time, the learning curve. I think it's one of the things about the cohesion that we have is that we can ask people not in the field, hey, your neighbor, like you can ask other people, I am a Rav, I'm looking for somebody who's good at working with OCD, the family is interested in family therapy with their daughter for eating disorder, this person has a substance issue, who do you know? I would say if you're asking me to do it like the Sarsa Dibros, so ask each other, feel comfortable. I think it's a wonderful idea to make friends with intercollegial departments. The previous speaker was mentioning how to do self-care. I mean, that 4-minute conversation I have with a friend who's a Rav at the end of a day about a topic sometimes normalizes it for me, and then I can go home and just not need to talk about it again. And I think that it's very helpful to have friends that say, oh, this person's good for this, but not for that. So that would be 1. 2, I really think that we all have to be humble that we don't know. You don't always know what's going on in the treatment room. Specifically in psychiatry, our patients sometimes have very horrible things to say about us. Doesn't mean good work's not happening. And so they might, oh, he's a jerk, or oh, you never know. But I think, so the second one would be get a lot of data before really making a decision about whether or not somebody is an outcast. And then the third one would be that when you make a referral, there needs to be patience, because a person's 25 years old, it's going to be more than 25 sessions before maybe you start to see progress. If it's talk therapy, if it's medicine, it can be, weeks and weeks until you get the right combination. So we are trying our best, but I think that I've learned from my colleagues, somebody who's not very good with one patient can be the best shaliach for another. And so, all the English-speaking MD psychiatrists sort of hear, I'll be the 7th doctor that somebody saw, and then they think I did a good job and the first 6 are terrible, but I have enormous respect for the people that they're bad-mouthing. It happens all the time. So I think, just Hashem's making the shidduchim. There's very good treatment, and as long as there's not something very clear ethically going on that's dangerous, I think it's hard to know what went wrong with a certain dud, but also 85% of the time if somebody writes for an SSRI, the person's going to get a bit better, meaning it might not be the ultimate best treatment relationship, but start with something. And we make mistakes. Medicine has mistakes. I wanted to, if I can add one part, the way that the confidentiality works for a professional, and please correct me if I'm wrong about in Eretz Yisrael, somebody can call me and leave me a message. I don't have to call them back. So if a Rav is like, listen, I know you saw him 3 weeks ago and you put him on this, and he's shaking in shul, and I don't know when his next appointment is, but he's embarrassed, or he didn't want to come to shul because his hands are trembling. That's fine. I don't need to call you back. And I might even call the patient and say, the Rav called. Or you could say, I told him to call you, and I told him I'm calling you.
And does that help? Do you
Oh, it's wonderful. It's wonderful. Everyone has my WhatsApp number. Go ahead. I mean, I'm busy, but I listen, and it helps. And I think that it's the same way with anything. If a teacher or if a girlfriend says, hey, can you, then we take the information and we're happy to use it. I think the idea of making referrals in general is, it doesn't have to be a bullseye, but you're saying to the person, this, what you're going through, is worth speaking to a professional about, and that's the main message.
So I want to, what's going to sound at first to undo what Dr. Alexander, but I'm not. It's actually just framing it. I'm going to piggyback actually on everything that Dr. Alexander just said. Whenever anybody comes to you for a referral, whether it's as a Rav or if it's a psychologist and I can't see them, it's not a good match for me. As Dr. Alexander said, part of self-awareness, understand that not every patient is good for you. That's also part of the self-awareness. But the first thing I would just say, just going stepwise, is that it's a huge achrayus. It's an achrayus both to give the referral and to understand that, so that's a mandate that we have. But when I give a referral, I feel very strong. It's my responsibility. And I tell the person, I said, I take the responsibility of giving you a referral very seriously. That I'm going to look carefully at you. I'm going to talk to you. I want to get a better understanding, because I can't just throw a dart at a board and say, oh, this person says he's good for this woman's good for that. That's not okay. I think that there has to be an element of research to a degree that a person can, because there is a lot of responsibility, a lot of achrayus that we have when we do give a referral, largely because of the response that Dr. Alexander mentioned. Very often, we're not Nevi'im. We're not going to know always if it's a perfect shidduch, but we have to try our best to make sure that, at least to the best that we can, that it is. To the degree, when I look for myself, if I know people personally, the first thing that I look for is, and it really touches on things that we're speaking about here in a different way, is I look first, is the person a mensch? Is the person I'm referring to, is a menschlich person? And a mensch in its fullest sense, is the person's yasher, the person's going to keep confidentiality, the person cares about you, the person's going to be, etc. People are like, what do you mean? Because unfortunately there are duds who are not just duds because there are duds like we make mistakes, but there are people who are unethical, unfortunately. And I think it's a big responsibility. After that, you look for training. Is the person well trained? Does the person have a good background? Especially in Israel, where it's a little bit more lax, but in the States, we're all very particular. With licensing boards, we have degrees from accredited universities. You want to check a person's training to make sure that there's a certain baseline level of competency. And then the last piece, which I think is really to a degree what Dr. Alexander was alluding to, is then you don't know. It's a little bit like a shidduch. You try your best, especially when it comes to therapy. You hope it's you try your best. Yeah, I think you'll be a good fit. This Reuven would be a good fit with Shimon. I'm trying my best. Now, the last piece is that if I can't do that, because I don't know the people, we don't know everybody, our circle of awareness, of influence is limited, so then I'll do exactly what Dr. Alexander mentioned, then you start to look for people. Then you can ask people, we ask colleagues, we have a lot of different networks, and we capitalize on that network to look for people like that. But even when I do that, I personally qualify. I say, look, this person I think is a good shidduch. I don't know him personally. And then, particularly in scenarios like that, I make it my business, from whatever capacity I'm serving in, just to follow up and say, by the way, hey, I referred you to so-and-so a month ago. Just, how's it going? I don't want to know anything else. I'm not prying. I don't want to know about the care. Do you feel like it's moving in the right direction? And very, very often, not often, always, people are very appreciative. Oh, you didn't just punt and kick me away? The answer is no. Like, I really care about you, so I'm not prying. I don't want to know anything about the clinical care right now. I just want to know, feel like you're growing? Do you feel like you're moving in the right direction? Do you feel like there's anything I can help you with? Support, and that's it.
Okay, it's 4:02. We said we would end at 4. I have a 5 o'clock meeting in Modi'in, so I have to go myself. I just want to say 2 last things. This was the one session that we didn't even talk about the war. And I think that that's important because this is important in the war, but it's also important after the war. And I know that when we spoke, Rabbi Shor and Zmira and I, we spoke about this really just being a beginning. And we mean that. We want to see what else could happen. So please let us know, what you think of today, what you thought of today, and let's all try and figure out how we can make this more than just a one-day conference. So that's what? Right. And I just want to end off very personally about something. I've never been at a conference where I cried. And I cried twice today. Once when Rabbi Howard was speaking, and once when Rabbi Bredowitz was speaking. I won't go into why at this point because it's late. But both of them had to do with, we heard every speaker except on this panel, because this is a little bit more technical, say, and I'm basically summarizing. You could learn all the theories and you could learn all the research and all the techniques and all that. but we heard everyone say basically that the most important thing is just our presence and being with people, right? And that's really, I think, what we have to offer. I just want to end, based on what I just said, I just want to end with a quick story. So 2 weeks ago, I'm in a t-shirt store in Modi'in. My son had his masak kumta, when you get he was in San Chanim, he got his red beret at the end of his training. And we're ordering shirts, because that's what you do when you go to a masak kumta, something funny, and the picture, and the insignia of the San Chanim, all that. So I'm standing at the counter on one end, paying. There are 3 people behind the counter, workers. Somebody walks in and comes up to the cash register and says the following. He says, my son was killed in the Nova Festival, and in a week we're having a ceremony at the site of the Nova Festival with the family and friends. We want to make t-shirts. Can you help us? So the guy says, yes, we can help you. Silence. And then they just go about the ordering the t-shirts. So I was busy paying for mine, and like around 60 seconds later, I walked over to him, and I said, Ani mishtateh b'tzarka, and I asked him what his son's name was, and I took his hand, I just squeezed it, and when I tried to take my hand away, he squeezed it. He wouldn't let go. And it took 60 seconds, but I felt, I'm not trying to say this to give myself credit. I have some rabbinic training, and I give rabbinic training. So what I'm saying is that sometimes it's just so simple that we miss it, right? That we don't think to do it because it's just so simple. Now, those workers were not bad people, right? They did not want to be sensitive. They're just uncomfortable talking about it. They don't know what to do. But we know what to do. We've done it. And I think that sometimes the simplest act, 30 seconds, 60 seconds, taking someone's hand, putting your arm around, well, I know you're not supposed to do that, whatever, but these kinds of simple acts, I think, could have the greatest effect and really show that we want to be with somebody, which all our speakers really said at the end of the day was the most important thing. So thank you very much for coming. Be in touch. Thank you to our wonderful panelists.